Good afternoon, everyone. Welcome to the second session of the training series, Implementing Medication-Assisted Treatment in Recovery Residences in Pennsylvania. My name is Jennifer Reha, Recovery Consultant with C4 Innovations. If you have not done so already, please take a moment to type your name and the recovery residence or organization you are affiliated with in the box to the lower left called Chat and Questions. I see many of you have already done that, so thank you. If you have not already, please go ahead. And we are so excited for everyone to be here with us today. This event is brought to you by the Substance Abuse and Mental Health Services Administration's Opioid Response Network and the Pennsylvania Alliance for Recovery Residences. Our Technical Assistance Center is dedicated to increasing access to recovery supports, and we achieve this work through a variety of mechanisms, including through technical assistance focused on systems transformation and developing the capacity of peer-run, recovery community, and family and youth-led organizations. I am pleased to announce today's presenter, Jenna Nesbitt, Recovery Consultant with C4 Innovations, who will be talking about considerations for owners and operators. I will be turning things over to her shortly, but first I'd like to review a few housekeeping items with you all. Please remember to mute your speakers if you're calling into the webinar, and remember to mute your microphones. The computer speaker can be muted by pressing on the green horn icon in the upper left-hand middle corner of the video feeds. Throughout today's sessions, we will be asking for your participation in several polls and discussion questions, and you'll see the polls on the left side of your screen. We invite you to participate in the discussion questions by typing your comments and responses in the chat and questions box. If you have any other questions or comments not specifically related to a discussion question, please do also feel free to enter those in the chat and questions box at any time. We'll gather all of those and address them at the end of today's presentation. We also have several resources related to this webinar available for download from our webinar resources box. To download a file, please click on the name of the document and then click Download File. This event is being recorded, and the recording link will be shared with all registrants after the event. You will also be able to review the chat and watch the presenters using that same link. All right, so I will be turning it over to Jenna. Jenna, welcome, and thank you for being here today.
Hey, thank you, Jennifer. Hello, everybody. My name is Jenna Nesbitt, and as Jennifer indicated, I'm a recovery specialist at Center for Social Innovation, now known as C4 Innovations. We are talking a little bit today about medication-assisted recovery and really want to delve into the considerations for owners and operators as they are working to implement accommodations for medication-assisted recovery. We're really glad you could join us today for the second session of the webinar series. First, a couple of standard Opioid Response Network disclosures. We work with SAMHSA to support technical assistance that's been created for the Opioid Response Network grantees, individuals, and other organizations. You can submit TA assistance requests to work with your communities and states. We'll provide you a little bit of contact information about that right here. So if you have any questions, you can submit a request to this email address, this website address, and we can help you out with that. So after attending the webinar today, participants will be able to demonstrate a basic understanding of the role of medication in recovery from opioid use disorders. So we will have a poll question coming up. Before we get started, we're going to do a little poll to get a feel for where you all are in the implementation process, if at all, for MAT accommodations in recovery residences. Medication-assisted treatment is the use of medications in combination with counseling and behavioral therapies for the treatment of substance use disorders. A combination of medication and behavioral therapies is effective in the treatment of substance use disorders, but particularly opioid use disorders. It can help some people to sustain recovery. So as we are moving into the poll, I want you to take a look at where you are with your recovery residents. Have you implemented that and you've had no issues, or maybe you're doing it and you need some help? Perhaps you're preparing to do it soon, or maybe you're thinking about it and would like to do it but aren't quite sure of what that looks like, or are you not doing it and not planning to do it? So just kind of take a minute and reflect on where you are in that process. So we have a word bubble exercise, and we want you to reflect on your experience and thoughts on what it's like or what it might be like to accept residents who use MAT. And then among the word choices that we have available, we have a poll actually, I got a little bit ahead. What we want you to do is move into the poll box and take a look at the choices you have there with regard to whether you're doing it or not doing or planning on doing it. And as you answer those poll questions, we'll take a look at tabulating them, giving you some feedback, and then we're going to do a little bit of appreciative inquiry on this. So far, 100%, all 2 of you who've responded are doing it with no issues. Wow, that's fantastic. I guess with that, we'll go ahead and sign off. I'm just kidding. That's wonderful to hear that you don't have any issues, and it's probably because you have a very supportive network in your area. So I just want to give it another couple of seconds to see if anybody else responds to the poll question. Okay, and we're thinking about it and would like to do it. So the poll has closed. Thank you, everybody, for voting. So we also want to do with you a word bubble exercise. And this will, we should have a list that will populate that may describe how you're feeling about implementing MAT accommodations in your recovery residence. And we'll give you just a minute to look at those answers and to pick the one that best fits where your house is right now. And what we will do is we'll progress through our presentation today, and at the end, near the end of the presentation, we'll show you the word bubble that best fits, that describes the answers that you all have provided for us. Oh, I love it. Many of you are supportive and interested and feeling prepared and willing. These are all very positive responses. Going to keep this open for just another couple of seconds. Make sure that we have everybody has an opportunity to respond. Okay, so we're going to continue on with the presentation, and this will be up here if anybody is logging in afterwards, and they can continue to answer the word bubble. I apologize, you guys. My screen just went wonky for a second. I went to advance the slide, and my apps tray came up. So let's talk a little bit about considerations for owners and operators. Really, when we look at the national landscape, for years, MAT has been considered the gold standard for addressing opioid use disorder, but there have been some issues. In medical care, there are few national standards for the training of addiction professionals and primary care professionals. In fact, our addiction professionals get more training than primary care, and right now those standards have not been standardized for everyone. And this also speaks to inconsistent education for academics who are doing research to support the field. Within the legal system, there has been a dominant culture of mandating and referring to 12-step mutual aid self-help and treatment with 12-step facilitation therapy curricula. The December 2016 CURES Act funded the Substance Abuse Mental Health Services Administration's large push of funding for MAT expansion. Specifically, those goals included to expand MAT by 25% nationally, reduce opioid mortality, and employ comprehensive approaches. As the federal government pushes for more MAT access, those being referred into services often face challenges with continuing their care because they cannot find recovery housing that will accept them. Many have already exhausted resources and relationships that were once supportive. Many of the states who are funding MAT expansion have mandated that recovery housing be prepared to accept people on MAT if they accept funding from the state. The primary goal of the STR, which is States Targeted Response, and SOR, which is States Opioid Response Funding, and that's the funding that comes from SAMHSA, to expand MAT capacity, has, as a result, put people in situations where they might have to terminate or taper quickly despite the clinical necessity to remain with medication-assisted treatment protocols because they have nowhere safe to live. Recovery residences have a distinct history from the Washingtonians to AA to the Minnesota model and therapeutic communities, but are now most commonly associated with 12-step fellowships. As a result, for years, recovery housing could really only be sourced from within the 12-step or mutual aid self-help fellowships, treatment centers, and criminal justice agencies. Because of this historical sourcing, accessing inventories of recovery housing, and particularly those willing to work with people on MAT, is still difficult. But we have seen a shift towards greater accessibility thanks to the proliferation of the National Alliance of Recovery Residences, Oxford House, and the previously mentioned STR and SOR funding to the states. In fact, the SOR funding requires states to support recovery residences as part of their design and application. And this puts states in a position of being very proactive with developing housing for people with OUD and specifically for those on MAT based on SAMHSA's expectation of funding outcomes. There are fair housing regulations of the Federal Housing Administration, or the Fair Housing Act, that applies to residences such as recovery housing because they fall under the FHA's definition of dwelling. Individuals using MAT are protected by federal regulations. They are also protected by the ADA, which is the Americans with Disabilities Act, if the residents receive state or local government funding, and by the Rehabilitation Act if the residents receive federal financial assistance. Accordingly, these residences may neither categorically exclude people using MAT nor insist that they abstain from MAT. We provided a case example here that came from the Department of Justice in May of 2018, setting a precedent for all types of residential settings. Even though this particular case did not happen in a recovery residence, this happened at a nursing facility where a patient was denied medications for opioid use disorder. And you can source further information about federal protections through the attorneys at the Legal Action Center publication called Know Your Rights, Rights for Individuals on Medication-Assisted Treatment. It is an HHS publication, and we have provided the link in the references section of the PowerPoint slide. Consistent with recently approved NAR standards, recovery residences are encouraged to maintain a supply of naloxone at all times and ensure staff are trained periodically in overdose reversal procedures. Based on the NAR standards, certified recovery residences maintain accommodations for residents to store medications securely and to take their medications following the prescription. See item number 25 of the 2015 NAR standards. I am going to cross-reference that later to ensure the location of that in the brand new standards. We started compiling this training before the new standards were produced. Likewise, Oxford houses autonomously decide on a house-by-house basis regarding medication storage and dispensation, but will typically provide or require the resident to purchase a lockbox for self-administration of the medication. Oxford House will also autonomously decide whether to standardize pill counts and other accountability measures, which are also overseen by the House chapters and governed by the House Charter. And we have referenced that information in the slides at the end of the deck as well. So that's a little snapshot on the current acceptance of MAT. We want to turn now to some distinct considerations. They include knowledge, culture shift, security, and mixed populations, and they present opportunities for us to explore. Within the knowledge domain, we see some challenges that include little research done historically on recovery residences, with the exception of a few key researchers such as Leonard Jason and Douglas Polson. The need for research has increased with energy pertaining to capacity expansion for MAT. While there have been some recovery housing providers who were accepting MAT before the federal funding, they have been limited in numbers and accessibility. Additionally, because people on MAT have been siloed within methadone clinics and office-based opioid treatment settings, they too have been difficult to source so that we can bring them and their voices to the table to help inform us about how to improve accommodations for them. However, there have been some great opportunities as well. In addition to the research done by Leonard Jason and Douglas Polson, there's burgeoning research at several academic facilities to include UT Health Science in Houston, DePaul, and NIH, that's the National Institutes of Health, as well as key informant interviews and learning collaboratives. Other opportunities exist, such as training and technical assistance, much like what we are doing with you right now, and more insights from lived experience for people coming forward and identifying as being in medication-assisted recovery. And that's really important because there is nothing about us without us. Let's talk a little bit about the need for culture shift, which also has revealed some challenges. Recovery residences reflect the culture of the local recovery communities in where they are embedded and these communities that support the recovery housing. Historically, abstinence-based, 12-step, and faith-based communities have been where we have found recovery housing. There have also been some key assumptions that communities are not supportive of opioid agonist treatment or medication-assisted treatment in general. I want to clarify here that opioid agonist treatment refers to methadone maintenance. There have been sharing of unfavorable studies as well about MAT and recovery residences, and the sharing of which has not included, it has definitely excluded, some reporting regarding the methodological design and some of the weaknesses of the study. So here specifically what we're talking about is the Major et al. Publication that was shared widely and gained some attention in the field in 2018. And it was essentially a study on an Oxford house that only included 98 participants in the sample, of which only 3 were on medication-assisted treatment. And that was shared widely and has been referenced in several other publications. The issue is that it was the first study of many studies to come to build a whole body of evidence regarding MAT acceptance in recovery residences. So when we share this study and we cite that recovery housing in general is a hostile environment for MAT, but we don't cite that this study is the beginning of a larger body of work, we are kind of doing a disservice to the role academia plays in supporting our growth to support recovery residences. However, of course, we don't want to talk about challenges without talking about those opportunities. MAT prevalence and recovery advocates have really called for us, all of us, to redefine abstinence, and that would mean to include prescriptions for opioid use disorder, just as we include abstinence for other classifications of drug use, as including medications for depression, so on and so forth, psychotropic medications. And we look at, for people with MAT, abstinence means they're abstaining from illicit substance use or previous problematic substances. Medication-assisted recovery does include the recognition of need for recovery support and housing choice to include people using MAT. It also includes education to create recovery-oriented values and diminish stigma for people using MAT, as well as inclusion of people using MAT in the recovery culture, which creates a psychological sense of community. It definitely requires us to operationalize many pathways as beyond a variety of 12-step resources, and they include MARA groups, which stands for Medication Assisted Recovery Anonymous, SOS, which is a secular group, and SMART Recovery, as well as other alternatives to the typical 12-step array. Medication-assisted recovery also recognizes that 12-step facilitation therapy, which is an evidence-based practice and probably the most widely used curricula within residential treatment settings, only has a 5 to 10% success rate, but that 12-step facilitation therapy for opioid use disorder success is increased. We see these outcomes increase when we also use MAT. Okay, let's talk a little bit about security challenges. There are some ongoing beliefs that are perpetuated about people using MAT, and often what we see is that they are extrinsically driven to taper by family, friends, and providers. This means that they may be actually pressured to terminate the use of medications, or they may just feel pressured with anticipatory stigma. And I just learned about anticipatory stigma this week. It's actually a thing. Some of the other security challenges revolve around concerns with diversion of any medication. Diversion of any medication within a recovery residence is no more likely than diversion of other illicit substances or legally sanctioned substances that are not allowed in the house. All of these things should be a concern for owners and operators. So, for example, somebody could bring alcohol or methamphetamine into a house just as easily to be shared, actually, if not more so, than opioids, because now there are so many restrictions on prescribing opioids. And so quite literally, it's much easier to obtain alcohol than it is opioids. So we really have to look at the stigma involved with medication diversion as far as a security challenge goes. However, there are some opportunities and some solutions, and that includes lowering risk for diversion with monitored administration of medications. Also, people who are in the early stages of methadone maintenance, they're required to go to the clinic daily and take an oral dose, which makes it a little bit harder for them to divert their medication. They can move into take-home status, but they must do so by demonstrating compliance with therapy and federal guidelines. It's worth noting here that there are 8 regulations that a patient must meet in order to qualify for take-home. They do not make it easy for people to get medications to take them home. Although it is not an ideal situation for obvious safety concerns, diverted MAT medications are still safer than a resident bringing an illicit street substance, such as heroin, into any recovery residence. But all of these concerns can be diminished by appropriate protocols and a strong policy and procedure. Mixed populations. Some of the challenges we face here are the assumptions that people using MAT and people not using MAT should be in separate housing. This is primarily based, my cat is objecting to this. This is primarily based upon our lack of experience with navigating mixed populations. It's also based historically on our tendency to silo people within their services that they are receiving for behavioral health. There are also assumptions that people on MAT may be dangerous for the recovery model. Conversely, that people not on MAT are hypersensitive to others presenting with sedation symptoms. There are some solutions here as well, and that includes understanding the need for a menu of services and housing types. This might include all MAT housing, non-MAT housing, and mixed MAT housing depending on your service structure within the NAR standards, whether your service structure is appropriately equipped to accommodate somebody who is utilizing MAT. Within mixed populations, it's important to establish a clear policy and procedure for offering support to a person experiencing MAT-related symptoms, as well as support for a person who's not using MAT who might experience a bit of a triggering effect in mixed company with those on MAT. We've done some key informant interviews at C4 with other certified recovery residences, recovery community organizations that provide housing, and hybrid organizations who do primary, behavioral health, and recovery services, and they all report having to approach some of these potential conflicts around navigating what I call the nodding triggering effect. And it's important to realize that everybody involved should have a safe place to express their concerns so that everybody can live in the house accordingly. Okay, so here's a quick discussion question. What barriers have you experienced in preparing your residents to accommodate individuals who are using medications as part of their recovery?
And Jenna, I just asked the question on the chat box whether any of the attendees today have a mixed population, and Saulene responded that her recovery residence does actually have a mixed population of people on MAT and not on MAT. So it'd be very interesting to hear from some of the attendees what their barriers were, or if they're currently still experiencing those barriers, and if those are different for having a mixed population or just individuals on MAT and not on MAT.
I mean, yes, we're really at an intersection. We have evidence-based practices for opioid use disorder, and we have evidence-based practices for recovery residences. So we do not currently have evidence-based practices for MAT and recovery residences. You guys literally are the burgeoning research that's taken place, right? So all of the outcomes that are going to be generated with STR-funded initiatives and SOR-funded initiatives are the foundations for beginning to look at what works and what doesn't work. But just from some of our key informant interviews that we've done at C4 for a variety of TA requests around this, the one thing we know for certain is that navigating that mixed population does happen and does require a case-by-case approach that should be very clearly defined in policy and procedure. So for instance, at Central City Concern in Portland, Oregon, where they have primary behavioral health, MAT, and recovery support services, they take a very individualized approach where the treatment team or recovery coach or both will come in to support the various residents as they try to navigate these situations. But at Healing Transitions in North Carolina, they have a slightly different approach, and that is to cross-train all of the recovery support staff with the clinic that is providing MAT. And so they do this very cool cross-system training development among all the staff so everybody knows how to best deal with some of these situations. So. Thank you to everybody who is responding to the discussion questions. It's very helpful for us as we work to provide training and technical assistance. So let's talk a little bit more about medication-assisted recovery. And there's another question. And you don't have to, this one is really more rhetorical in nature. But this is a question that often arises in the recovery community, and that is it really recovery if you're taking a medication that can get you high? So let's review session 1 a little bit. Medications for opioid use disorder are formulated differently, and while they can be used, maybe possibly, somebody might think they can use them to achieve an effect. It is really difficult to do so. Buprenorphine, for instance, has a ceiling effect. And so it doesn't matter how many extra doses a person can take. They're not going to break through that ceiling and get high. But there's something to be said for differentiating between the symptoms that any opioid can present for a person that's taking them versus the actual effect of getting high. Often people are illicitly obtaining medications to avoid withdrawal or being dope sick, to use a vernacular that I'm common with as a person in long-term recovery. In other cases, people may be obtaining these prescriptions because they it's still safer for them than going out into the streets to obtain counterfeit pills, which are often pressed with fentanyl, or illicit substances of unknown origin, which may contain fentanyl. So it's very, very important for us to kind of take a look at what our attitudes are with regard to how we're treating other people who are using substances for recovery. Okay, redefining recovery for many. The use of medications for opioid use disorder in medication-assisted treatment is a life-saving measure. Recovery and abstinence can further be defined as abstaining from alcohol and other illicit substances which are not prescribed in the MAT protocol. For instance, people in Overeaters Anonymous do not abstain from all food, just certain foods. So they have abstinence-based foods that they use in that 12-step program. Oops. Sorry guys, I'm having to forward between two screens at once so I can read my notes. Recovery is a process of change according to SAMHSA, and this was their 2012 definition. It's a process of change which individuals improve their health and wellness, live a self-directed life, and strive to reach their full potential. And this occurs within the supportive dimensions of health, home, community, and purpose. And I know you guys all should know this very well. Recovery residences provide a foundation of support upon which sustained remission and ongoing recovery may be built. But as we turn to medication and the question of recovery status, this is a William White article, and I turn to him very frequently because he's such a prolific author about recovery. But he basically contends that the long-term cultural and professional foundations of medication-assisted treatment and its legitimacy across diverse communities of recovery rest on a well-established concept of medication-assisted recovery, even though the promulgation or the creation of such concept risks creating a special recovery status for MAT patients. However, there have been some consensus panels of policy, clinical research, and recovery advocacy leaders that were convened through the Betty Ford Institute Consensus Conference, SAMHSA, CSAT, Recovery Summit, and the United Kingdom Drug Policy Commission. All of these various convenings generally include three essential elements of recovery, and that is A, the resolution of drug-related problems, with resolution variably defined as sobriety or abstinence, or diagnostic remission, B, improvement in global health, and C, citizenship, which includes positive community reintegration. So with defining recovery within the context of MAT, that requires cultural and professional understanding of the distinction between addiction and physical dependence. Dependence is physiological. However, addiction is physiological plus compulsive behaviors. That is a very just basic definition. If you were to look at the ASAM, the American Society for Addiction Medicine, you'll find a much lengthier publication that discerns between the differences. For the person or family involved with MAT, an understanding of the distinctions between use of medications as an aid to recovery and the use of drugs as a threat to recovery is very important. This is a complete paradigm shift from a deficit-based or pathology-based paradigm to a strength-based and hope-fueling paradigm. So MAT-related discrimination does happen, and it happens frequently still. This information has been compiled on the slide from the Recovery-Oriented Methadone Maintenance Monograph by William White and Lisa Mahort-Torres. Addiction and MAT-related social stigma contributes to social isolation, reduces help-seeking, and undermines long-term recovery. And we include this in our discussions because even though they specifically wrote on methadone, it applies to people still who are taking buprenorphine and to a much, much lesser degree naltrexone. We don't really see as much stigma with naltrexone as we do with buprenorphine and methadone. But these stigmas particularly are concerning among those with multiple circumstances that society deems as discrediting, such as obviously addiction, methadone treatment, but then further discrediting might be somebody who's struggling with psychiatric illnesses, HIV or AIDS, minority status, poverty, and homelessness. So when you compile all of that together, it's quite a conundrum of stigma. People using MAT, particularly those enrolled with methadone maintenance, have never received full status as a patient. And we could add, they have never received full status as in recovery. And we are going to do a whole webinar session on this. I believe that is our 5th session slated for a few weeks from now. So opioid treatment providers and the clinics that dispense methadone have yet to be viewed as on par or equivalent with hospitals and outpatient medical clinics for healing properties. The historical stigma attached to methadone and the broader arena of medication-assisted treatment has denied MAT patients the status of recovery and has left them isolated from mainstream community life and existing in limbo between cultures of addiction and cultures of recovery. They've lived in a bit of a purgatory for decades. So stigma is prejudice, and prejudice leads to discrimination. Again, we'll talk more about this in our 5th webinar. The stigma is one of the reasons why you'll hear us talk about both MAT and MAR kind of interchangeably, because we're really trying to bring a new language to the field. So recovery housing, accommodating people using MAT. SAMHSA's recent draft guidance presents an official definition of recovery residences, which you can see on this slide and the next slide. SAMHSA espouses that this definition has been proposed to serve as a benchmark from which to ascribe best practices and suggested minimum standards and utilized to encompass the basic tenets as set forth in statute, in which they're referring to the recent SUPPORT Act. The definition stipulates the inclusion of medication-assisted treatment and other FDA-approved pharmacological interventions. Now, one thing that we need to point out is this is a draft, and it was a guideline that was published for comment from stakeholders, and so it is subject to change. Many of the comments that we've seen submitted have requested a polishing of the language and the messaging, and we're sure it's probably going to change. The question is by how much. That is currently unknown. So recovery housing, just another reiteration that it should be substance-free, does not prohibit from including prescribed medications as taken by a physician. So finding a good fit, as discussed earlier, there are many challenges with implementing accommodation for those using MAT in recovery residences. And these challenges are often drawn from beliefs, unclear administrative requirements, and security concerns. Let's talk a little bit about the beliefs. Looking back at the challenges we've already reviewed, which include knowledge, culture, and security, in this example, the statement in the middle bullet reflects beliefs that are purely derived from some subpopulations of mutual aid self-help groups. Unfortunately, running a recovery home does qualify as a business, and therefore this type of discriminatory statement is problematic, and actions that reflect this type of statement are against the law. Additionally, statements such as these reflect a lack of knowledge about the science of addiction and treatment and those implications for people in recovery. And I just want to point out that this bulleted statement about we don't allow people on mind-altering substances in our house actually is a statement that was made to me by a local recovery housing provider. So that's why it's been included. Some administrative requirements. Other biased statements cite that any positive UA in a recovery residence is problematic, regardless of whether the prescription is valid. And this is based on, for the people who make these types of statements, this is based on more funding needed for more accurate tests, as well as limited resources to administer tests, and the development of well-defined policy and procedure for implementation. But recovery residences provide a supportive service, and they are still a business, and in Pennsylvania are licensed accordingly. So they're going to have to be flexible with accommodating when possible. Owner-operators express reservations about the possibility of sharing substances such as methadone or Suboxone. The recipient of a shared substance is probably not on a therapeutic, if any, dose and should seek physician guidance. This is an opportunity to intervene or re-intervene for recovery support, to be supportive with recovery. It is, again, difficult to achieve effect from these medications, and sharing is problematic in sober living. However, sharing opioid use disorder prescriptions are still safer than bringing in illicit substances, as previously mentioned. The social model of recovery works, but there are always going to be some outliers. So owners and operators need to be ready to address that, regardless of the classification of the substance being brought into the house. In 2017, AA's World Service Organization indicated awareness of attrition. Not everyone wants to do AA or NA and should not be shamed for it. They should have other options. There are many recovery housing providers, to include faith-based and 12-step affiliated, that do not allow for medication of any sort. For those using medications for opioid use disorder, where would they go if not into a recovery residence that offers a safe and secure foundation? Regardless of whether a person is using that, owners and operators should be prepared to understand and accommodate all other recovery program pathways. Because quite honestly, not everybody is comfortable in a 12-step meeting. I know that as a person in long-term recovery, that is where I like to go, but my responsibility statement does not extend only to those people who want to ascribe to AA or NA. My responsibility statement is to help anybody. Sorry about that. Let's talk a little bit about other recovery supports. We've provided you a list with some well-known alternatives to 12-step meetings. Some of these recovery programs and communities may be more receptive to people who utilize medications for opioid use disorder, and they're very commonly found in many cities around the world. These programs are all growing and typically list available meetings on their websites. SMART, for instance, has an online meeting locator, and if you cannot find a SMART meeting in your area, you can attend a SMART meeting online. So we kind of take a minute to look at, if you're not currently implementing protocols to accommodate people on that, how can we help you? This would be a great opportunity for us to review our word bubble that our room moderators, Melissa and Vanessa, who we have not appropriately thanked for all their hard work in the background, have put together for us in the meantime. And so this is a word bubble that basically describes how you guys are feeling about implementing MAT accommodations. And I love that supportive is so big.
Yeah, Jenna, I wanted to say that I think that it's a good sign that supportive, willing, and ready are our three biggest responses. But we do obviously still also want to recognize that there is some apprehension, some bit of people feeling concerned, and the recognition that there is some level of risk that has to be addressed. One of the discussion questions that's come up during the session today around barriers has to do with individuals in the recovery residences being prescribed or getting, not through direct prescription, medications for high blood pressure, muscle spasms, seizures, etc., that there either is or is believed to have an interaction with MAT medications and give more of a high feeling when you're taking MAT medications. And the general response seems to be that that is not considered officially a relapse or an abuse of the substance because it is not an illicit substance, but it's clearly not giving people the opportunity to fully engage in recovery if they're trying to find substances that are going to give them that same escape feeling. And that's probably some of where we see some of these responses for it being somewhat concerning or risky or apprehension. So if you wanted to say anything about that or have any thoughts about that, that certainly seems to be a concern from the attendees today.
And that is a legitimate concern, and it speaks to the lack of training and education for the whole entire workforce that's serving the field for SUD, OUD, and recovery. So for instance, I went in recovery just a couple of years ago, went to a physician, and they prescribed me gabapentin, which is also Neurontin, I see in the box, for off-label use. And the doctor knows I'm in recovery. And I asked about any side effects. I really just kind of interrogated this physician on whether this is a safe medication for me to utilize. And I took the medication on a Friday night, and as I was sort of falling into slumber, I felt an effect from the medication. Now, some people will tell you that's absolutely impossible, and I disagree with anybody telling me what my experience was, because when I woke up the next day, I told my husband, and he said, maybe let's talk to your sponsor, and I did. And of course, it was up to me as to whether I wanted to continue the medication. I personally didn't feel comfortable with feeling an effect, but medications like this can do what we call potentiate, which means make greater the effect or magnify the effect of opioids. So absolutely, everybody has to be involved with a person's treatment and have clear communication. So all of the prescribers should be discussing with one another, or at least the patient or the resident needs to be able to tell one provider that he's on MAT or she's on MAT. However, this brings up a whole other level of confidentiality and fears, anticipatory stigma. If you're telling your primary care provider that you're on opioids, there's a whole new world we have to kind of unpack together as we look at medications and houses, and I can see where that is concerning. So it is quite simply easier for a recovery residence owner or operator to just say, nope, not going to do it because of the liability and all of the frustrations. And there's room for us to look at then what houses are willing to move forward and really provide the most supportive environment that's possible for somebody that is taking a myriad of medications versus just allowing in people who don't require medications for opioid use disorder. Go ahead.
I was just going to agree with you and say that in session 3, that is when we're going to begin discussing coordinating both with outpatient treatment programs, but then coordinating with the medical provider community broadly, and how we establish those relationships, how we get the forms and procedures in place to be able to do that. So I think you make some really good points about there needing to be education, not just for recovery residence operators or even recovery residents, but other healthcare providers and other healthcare sectors. So one of the next questions that Maria brings up is that she has some concerns about people feeling or being high when they take MAT. Can you say something about that?
Oh, yeah, absolutely. So people most often are going to present symptoms associated with medications when they are titrating on their dose. And dose titration is a very personal medical protocol because every metabolism is different. Everybody metabolizes substances differently. And one of the examples I like to use, if we were all in a room together and we looked around at the different ways our bodies are shaped, some of us are long and lanky, and if you're like me, you might be a little more curvy. And so just by looking at different body shapes, then you can infer that there are different metabolisms. Metabolism is not just about the way your body uses food to store and produce energy. Metabolism is also about the way your body will ingest and exhibit symptomology related to medications or any substance. And so everybody's body is different. So dosing, therefore, requires a close contact with the physician. And oftentimes, we see sedation or sometimes even analgesia within the titration period of dosage. Also, again, as we discussed, if there's any potentiating medication that is also being ingested, that can magnify some of these symptoms. But for methadone and buprenorphine, there's a blockade that takes place when dose titration is happening. And so after titration has taken place and somebody is at a therapeutic dose, then there should be no, somebody should not be high. And as we've mentioned both in this session and the previous session, with buprenorphine, which you guys may more commonly know as Suboxone or Subzol, there's a ceiling effect. And so it doesn't matter how many doses a person takes. They're not going to break through that ceiling and get high. That doesn't mean there's not a little bit of an effect, but they're not going to be getting high from increasing their dosage. So while we have concerns about people exhibiting effects, I think it's very important for us to start looking at the language we use. And instead of talking about getting high, we should be talking about whether somebody is experiencing or presenting with effects relative to the dose. Does that make sense? So we do have some resources for you. Recovery Research Institute has a lot of great resources on pharmacotherapy, which is another term that we use for medication-assisted treatment. Addiction Technology Transfer Center has tons of resources. Faces and Voices of Recovery, Facing Addiction with NCAD, Medication-Assisted Recovery Anonymous, and the American Society for Addiction Medicine, if you want to get really nerdy about it. They have some extensive resources, but one thing that's not listed on this slide is the National Alliance for Recovery Residences. That is a primary resource that you can turn to, and we recently did C4 and NAR and the National Council have a new document that was just released on MAT in recovery residences, and their basic suggestions are that we really have to avoid categorical, meaning just excluding based on a presumption, categorical exclusions based on use of medications. Such exclusions may violate the Federal Fair Housing Act and the Americans with Disabilities Act, and we just want you guys to be careful because you are a business. The applicant's recovery goals or a potential candidate for residency in your home, their recovery goals should align with the recovery residence's philosophies, services, and support offerings, regardless of their status in medication-assisted recovery or with opioid use disorder medication. And so you guys can find a link to that new document on the NAR website. We highly suggest, it wasn't included because we started putting these slides together before it was finalized. And so we really suggest that you do go take a look at that document. And here are some of the references that we've included for your reference that include NAR standards, the Oxford House policy regarding MAT, the article in question that has been circulated, which we really want you to take a look at the methodology in that article before you continue to disseminate that as a reason for not allowing MAT in recovery residences. And then, of course, William White has done a lot of work. And here's the link that I referenced earlier to the publication regarding your rights as individuals on medication-assisted treatment. And you can reach that as well as the DOJ article in Sober Law News regarding some of the precedents that have been set around residential settings and denial of medications for opioid use disorder. So I think that our timing is pretty good today. And we only have a few minutes left, so if you guys have any further questions, now would be the time to put those questions in the chat box.
Yes, thank you all for your time today. As Jenna said, if you do have additional questions, please feel free to enter those in there, and if we have time, we'll address them still this afternoon. Otherwise, We'll gather them and address them at the beginning of the third session. Also in our third session, we are going to discuss whether certain types and levels of recovery residences are a better fit for people in medication-assisted recovery, the legal considerations around your screening tools and your relapse or eviction policies, moving from MAP accepting to actually building a medication-assisted recovery capable environment. And then, as I mentioned before, we're also going to start discussing how we collaborate with other treatment providers and the medical community. If you have any additional questions, as I mentioned, please feel free to put those in the chat box. Also, we always encourage you to please consider reaching out to request technical assistance from the Opioid Response Network by going to opioidresponsenetwork.org and click on the Send a Request button at any time. Again, thank you so much for joining today's session. Thank you for your participation, and we hope you have a great rest of your day.
Just one more thing before we close out. Our room moderators have asked us to let you know that you can access these links in the PowerPoint, which you can download from the download box. So we do just want to make sure you have that accessibility. And thank you so much, Jennifer, for all of your hard work, as well as Vanessa and Melissa, who are behind the scenes making this all happen.